Hey guys, this is with Nursing School Made Easy. Today's topic is going to be pancreatitis. Now, I've made a previous lecture that had a CT image on it, and this was going to be a little bit more just about what you need to know as far as the nclex goes. So it's going to be a bit more in detail. Also, this is going to cover a little bit of hypocalcemia, hypomagnesemia, gallbladder stones. So if you don't remember that information, please go back to those other lectures because it's going to come in handy as we go on with this lecture. Okay, so let's focus on, again, pancreatitis. And as always, let's break down the word pancreatitis. So we know that the pancreas is involved, and most importantly that it is inflamed. There's inflammation, and anytime that there's inflammation, always suspect that the WBC will be elevated. Okay, so just keep that in mind. And let's use a different size of pen here. And if you refer back to the CT image, this will make a little bit more sense. But just draw a person here. And again, we have the liver here. This would be the diaphragm. Okay, and then you'd have the esophagus coming down, the stomach, and then the pancreas is going to sit about here. It's going to be, again, a feathery looking organ. We have the gallbladder here, and also remember that the liver is going to have a duct. So is the gallbladder, so this would be the hepatic duct, cystic duct, and somewhere along the way the pancreatic duct. They're all going to combine, and eventually they'll all dump into, forget about that, they're all going to dump into the small bowel. Okay? So again, if there's a gallbladder stone and that gallbladder stone manages to get down here, it's going to cause an occlusion, a blockage. Okay. Now again, the pancreas, it's going to secrete amylase. It's going to secrete lipase. So if this is blocked, then what's going to happen is all these enzymes are going to be backed up into the pancreas, and something called autodigestion is going to occur. And that simply means that these enzymes are going to begin to digest the pancreas. Okay? And that is going to cause inflammation. It's going to cause pancreatitis. Now, this is, for example, one instance in where gallstones cause this problem. Okay, so what are some causes? Number one, we just briefly talked about it. Gallbladder stones. And more importantly, gallbladder stones that cause an occlusion, cause a blockage. Now, here we just talked about how this is going to cause an occlusion for both the pancreatic enzymes, the liver enzymes, and the gallbladder. Well, the gallbladder secretes bile. Okay. The liver also secretes enzymes. So if these are affected, if the liver is affected and it can't dump its enzymes into that hepatic duct, well, then liver enzymes are going to go up. Bile is going to go up, or bilirubin is going to go up. Again, that is due to gallstones. So again, here's a cause: gallbladder problems. More importantly, gallbladder stones. Number two, alcoholism. Does your patient drink alcohol chronically, large amounts of alcohol? Because alcoholism can cause pancreatitis. And these are your major causes for pancreatitis. There are other things, for example, viral infections or bacterial infections. Another thing that can cause this is a duodenal ulcer or a peptic ulcer. Excuse my crude drawing, but here we see the stomach laying next to the pancreas. So if there's an ulceration here, that gastric acid is going to come here on the pancreas and begin to also irritate it, digest it, and again that will result in pancreatitis. Number 5, some type of surgical procedure. More specifically, maybe some type of procedure with a gallbladder, for example, lap chole, or some type of stomach, gastric bypass, maybe some type of resection. That can also cause pancreatitis. Now, what are your clinical manifestations? What are your signs and symptoms? What do you look for in your patient? Now, we just talked about a couple of them here briefly. So let's get right into it. Okay, let's focus on your signs and symptoms, or your clinical manifestations. Number 1, pain. More importantly, you have to know the location, because your nclex likes to know, or wants to know, if you know where this pain is at. So more specifically, it'll be in the epigastric region and or the left upper quadrant region. So make sure you know both of these, either your epigastric or your left upper quadrant region. Now, this pain is going to increase anytime the patient eats, and especially in the supine or recumbent position. You'll have nausea, vomiting, and since they're having pain every single time they eat, and since they are having some nausea, vomiting, they will most likely also have weight loss. Now, if this is a chronic thing, this weight loss will also result in some muscle atrophy or muscle wasting. We just talked about this a little bit ago. Your WBC, if you were to check it, it's going to rise, it's going to increase, it's going to be higher. So you would look at your WBC. We just talked about this earlier also. Your bilirubin levels will go up. Other things that will go up, like I told you before, are your liver enzymes, your alkaline phosphate. Or excuse me, alkaline phosphate, your AST, ALT may also be elevated, and especially if there's some type of gallbladder, a gallbladder stone causing an occlusion, these are all going to be elevated. Now, a couple of other enzymes that you want to look at are your amylase and lipase. Make sure you know these for the nclex, amylase and lipase. More importantly, your amylase will actually be seen in urine, and that is not supposed to happen. You don't have digestive enzymes in your urine, but if you were to do a UA, you may actually even find amylase in the urine. So make sure you know that for the nclex. 7. You have decreased abdomen sounds or hypoactive sounds. 8. Atelectasis. Now, why would you have atelectasis? Why would the lungs be involved? Well, if we look at my awesome picture here that we did a little bit ago, if you have this amylase and lipase and other pancreatic enzymes, what they do is they digest food. that is their sole purpose, to digest materials. Well, if this is beginning to leak out of the pancreas, you have all these enzymes coming out, leaking out. Well, if it's sufficient amounts, they can actually begin to digest the diaphragm. They can actually begin to leak into your lungs. Okay? You have accumulation of these enzymes here that are again causing damage to the diaphragm region, again to your lungs. So now you get these enzymes in here causing lung problems, making it difficult and painful for your patient to breathe, resulting in atelectasis. So with acute patients, you always want to listen to their lung sounds. You always want to look at their respirations. Are they having difficulty breathing? What is their O2 sats? If their O2 sats are down, then you want to put some oxygen on, because again, you always worry about their lungs. Have they been affected? Number 9. Cleanse sign of, and if I'm pronouncing that wrong, I apologize. Make sure you know this for your nclex. Okay. Now, if the auto digestion is severe enough, what's going to happen is your pancreas, remember, it's getting blood to it. So if the source of blood, that's vein, artery, something that's bringing blood to the pancreas, if that begins to also be digested, what's going to happen? You're going to have blood spilling inside your abdomen. This can accumulate in your periumbilical region. So you actually begin to see some bruising. So check your patient. Do you see some bruising in the abdomen, in the flank region? That may be a huge sign that there is active bleeding inside, again, due to the pancreas being affected. Okay, so that is what Coulin's sign is. That is bluish discoloration in the periumbilical region. Number 10, steatorrhea. Now these are large, fatty, smelly stools. Now again, you're supposed to secrete amylase and lipase. Lipase is supposed to break down lipids, break down fats. Well, if you cannot break down lipids, if you cannot break down fats, that stuff is going to go into your bowel directly, and you're going to, anytime you have a BM, you're going to get rid of it. So these are going to be very large, bulky, foul-smelling stools. Okay? And again, you can have that because you have no lipase to digest fat. We talked about this a little bit ago. Muscle wasting. You're not eating anything. Therefore, you're going to lose muscle mass because your body needs protein, so it's going to pull protein from the muscles. Jaundice. And due to increased bilirubin levels. Diabetes. Again, this is if it's chronic. Remember that your pancreas, you have beta cells in it. These beta cells produce insulin. So if your pancreas becomes damaged and those beta cells are no longer able to produce insulin, your sugar levels will go up. So again, you would end up with diabetes. So for those patients, you would want to check their sugar levels. And if they're elevated, then you would either give them insulin or something like glucophage, glucovans, metformin, those type of PO medications to control their insulin. Now something else that you may give would be pancreatic enzymes. But we will get to that with your interventions. Okay? Diagnostic studies. How will you diagnose this? Well, your big one that we talked about earlier, your amylase and lipase levels. These will be your serum amylase and lipase levels. And also, I told you before, you can do a UA and you'd find amylase in the urine, which you're not supposed to find. So if you find that, that's a big sign. 2, increased glucose levels. And we just talked about that a little bit ago. Increased bilirubin levels. Increased liver enzymes. And hopefully this is all repetition by now. 3, decreased calcium levels. Now, since they have decreased calcium levels, you would also want to check for tetany. And again, this is why I told you in the very beginning to make sure you check out the lecture on hypocalcemia so that you understand this concept here. Number 4. So these are lab studies here to help diagnose. Imaging studies, you would want to do a CT abdomen. Okay? Now, you can also do an ultrasound. But think about it. Anytime you do an ultrasound, you're going to be pressing down. If you press down on the pancreatic region in an area that is in pain, that is tender, you go and press down on that area, that patient's going to be pretty upset. They're going to be pretty mad. They're going to be uncomfortable. So the ideal diagnostic study would be CT. More importantly, CT with IV contrast. And PO or oral contrast. Now, if you're going to give IV contrast, you must again make sure that are they diabetic, yes or no? Is their kidney function within normal limits? Now, I say this cautiously because typically to get the best CT scan, you don't want with PO contrast. But most times your patient is going to be in MPO status. So you may not give PO contrast, okay? Now, let's get into your interventions. Number 1, provide adequate pain control. And this is a must because if you've never seen somebody with acute pancreatitis or just chronic pancreatitis, pain is probably the number 1 priority. I mean, this is excruciating pain. So you want to make sure you control it well. So you may give something like morphine. This again will be dependent on what the physician prefers. But make sure you always take care of that pain and also assess that pain. Are you having good pain control? Are you giving too much pain medicine? Are you sedating? Are you over sedating your patient? So again, make sure you monitor that pain control. Number 2, hydration. We talked about how they're not going to want to eat or drink anything. They're going to be maybe nauseous, maybe vomiting, so you want to hydrate them. So you could possibly give something like LR. Now we also talked about the possibility or likelihood of that pancreas actually hemorrhaging. So if they have a decreased hemoglobin, decreased hematocrit, then you may give something like packed red blood cells to bring that blood or those blood levels back up. Number 3, you want to place them in MPO status. You want to let that bowel, that area rest. Okay, anytime you eat, your pancreas is going to try to secrete those enzymes, and that is only going to irritate the area more. So you'd put them in NPO status to prevent that from occurring, prevent that pain from occurring. The other thing that you would also do is put in an NG tube and perform some suction. Again, you're going to get rid of those gastric contents to, again, prevent pain from occurring. 5, you'd want to do some antibiotic therapy. Again, this will be determined by the physician, because the pancreas has a likelihood of becoming infected, so the antibiotic therapy may be prophylactic. 6. If the problem is due to a gallbladder stone obstruction, then you would remove the gallbladder. And again, this would be ordered by the physician, right? He would take care of this problem. So some type of surgery may be performed. And again, you would do all your interventions for a surgical patient. 7. I'm running out of space here. You'd provide antacids. Again, you would provide antacids, maybe H2 receptor blockers, PPIs, or your proton pump inhibitors. Now, the whole goal of this is to decrease acid secretions and, again, prevent pain. So, again, examples of your PPIs would be something like omeprazole, Prilosec. An example of H2 receptor blocker would be something like Zantac. Let's see, where are we at here? Number 8. Insulin. Again, if the pancreas is no longer functional, you have to give that patient insulin to bring those high sugar levels down. Before you can do that, you're going to have to do a glucose check, glucose finger stick. Check those glucose levels. Are they really, really high? So that you actually know how much insulin you're giving. Number 9, you're going to provide PO or oral glucose meds, and we talked about these earlier. For example, glucophage, glucovans, metformin, something like that, to again control those sugar levels that are rising. Number 10, again, you're going to observe for tetany. And again, that is due to decreased calcium levels. 11, you're going to monitor for hypoglycemia. Excuse me, please forgive me for saying that, but hypomagnesemia. And last but not least, you will tell your patient to maybe take some PO pancreatic enzymes. This would be more if it's a chronic situation. Their pancreas is affected enough that it can no longer produce those enzymes, so you're going to have to provide those superficially. You're going to give those, again, PO, and you're going to tell that patient to take it with meals. Now, examples of these include pancrease, Zenpep, and something called Creon. And again, make sure they take these with meals, and they may also take them with their PPIs or H2 receptor blockers.